Welcome to While We Were Distracted, the podcast where we explore topics that often get overshadowed in the rush of daily life. Please take a moment to like and subscribe. It really helps.
Welcome to the deep dive. We take complex information, legislation, research, those big ideas, and we try to pull out the nuggets you really need to be well informed.
And today, we are wading right into maybe the most charged policy debate there is in America, healthcare reform.
Specifically, we're doing a deep dive into the actual text of the 2025 reintroduction of the Medicare for All Act.
That's right. It's known as S-1506 in the Senate and H.R. 3069 in the House. And this proposal, well, it outlines a really complete structural overhaul of the entire U.S. health system.
So our mission today is pretty straightforward.
Yeah.
Let's get past the headlines, the political talking points, and look at what the bill actually says. What are the mechanics, who gets covered, what's included, and the big one, how does it get paid for?
The basic idea, the foundation, is to set up a universal single-payer national health insurance program. And it would be administered completely by the Department of Health and Human Services, HHS.
Okay, but before we get into the weeds, what's the current status, politically speaking?
Right, that's key. These bills were introduced back in April, got referred to committees, Senate Finance, House Energy and Commerce. But as of today, which is mid-October 2025, they're basically stalled. No further action scheduled.
So it's a huge vision for reform, but politically it's stuck for now.
Exactly, trapped in that partisan gridlock. But understanding the vision itself is still crucial.
Agreed. Okay, let's unpack that vision, starting with the biggest promise, universality. When the bill says everyone is covered, who exactly does that mean? Are there limits?
Well, the entitlement section is written to be deliberately broad. The text says, every individual who is a resident of the United States is entitled to benefits.
Resident. That sounds simple, but I bet it's not.
It's not. The key detail is that the Secretary of HHS is required to establish rules defining residency. It's not just, having an address.
Okay, that residency issue is critical. Does the text tackle that common concern? You hear it a lot about people potentially traveling to the U.S. just for medical care, what critics sometimes call health tourism.
It does, yeah. The bill explicitly requires the Secretary to create rules specifically designed to prevent individuals from traveling here solely to get healthcare under this new system. So it tries to define residency for those actually living here while closing off that specific loophole.
That's a really important clarification. Okay, what about choice? Does the patient still get to choose their doctor or hospital?
Yes, absolutely. The bill specifically guarantees that individuals can get services from any qualified provider who agrees to participate in the program.
And that's backed up by non-discrimination rules.
Very strong ones. It explicitly prohibits excluding people or giving them fewer benefits based on the usual things like race, age, but it also specifically lists disability, citizenship, religion, sex, and importantly, it specifies this includes gender identity, sexual orientation, and termination of pregnancy.
Okay, that non-discrimination language is very clear. Now, let's get into the benefits package itself. This is where it gets really interesting, right? Because our current system often has big gaps. Think mental health, dental, long-term care. What's actually in this comprehensive package?
It's huge. It goes way beyond just standard hospital stays and doctor visits. It specifically pulls in services that, frankly, bankrupt people today. Things like oral health, audiology, and vision care are all covered.
That alone is a massive change. What else?
It also covers all mental health and substance use disorder treatment, including inpatient care, prescription drugs, and medical devices, too, including all FDA-approved contraceptives.
And what about those areas often debated, like comprehensive reproductive care and gender-affirming care?
Both explicitly included. The text mentions comprehensive reproductive care, specifying abortion and assistive reproductive technology, and comprehensive gender-affirming health care is also listed as a covered benefit.
Wow. And you mentioned long-term care.
Yes, and this is maybe the biggest structural expansion. It includes home and community-based long-term care services and supports. Think about helping people stay in their homes longer. That's a potential game changer for millions of families dealing with elder care or disability support costs.
Okay, so we've got universal coverage. It's incredibly comprehensive. The natural question everyone listening must have is, all right, what's the catch? How much do I pay when I actually need care?
And the answer, generally speaking, is nothing. Almost nothing at the point of service. The main rule is zero patient cost sharing.
Zero. So no deductibles, no coinsurance, no co-payments.
Correct. For nearly everything.
Yeah.
And it also explicitly bans what's called balance billing. That means a doctor or hospital can't bill you for the difference between what the government program pays and what they might charge privately.
Hold on, I thought I saw one small exception to that zero cost sharing rule. Something about prescription drugs.
You're right, that's the single nuance. While almost everything else is free when you get the service, the Secretary of HHS it's not required, but they may set up an evidence-based cost-sharing schedule just for prescription drugs.
Okay, may. But even if they do, are there limits?
The strict limits.
Yeah.
Yes. First, any cost sharing has to encourage generic drug use and it can't apply to preventive medications. Second, the absolute maximum anyone would pay out of pocket per year is capped at $200. That's per person, and it gets adjusted for inflation over time.
Only $200 a year, max.
And maybe even more importantly, that $200 cap is completely waived, meaning it's zero for anyone with income below 250% of the federal poverty line.
Okay, so for a huge portion of the population, even prescription drugs would likely have no copay.
That's the intention, yes. Remove financial barriers to getting necessary medication.
All right, this picture of universal, comprehensive, virtually free at the point of service coverage, it completely changes the dynamic. But it also sounds incredibly expensive, even if there are downstream savings from eliminating administrative waste or whatever. Let's pivot to Section 2. How does this whole thing get funded? How do doctors and hospitals actually get paid?
Right, this is where the architecture really shifts. You move away from our current fragmented, market-driven system towards centralized cost control. The core mechanism is something called the National Health Budget.
A national health budget. So the government decides basically the total amount the entire country will spend on healthcare each year.
Exactly. Every year, the Secretary of HHS establishes this budget. It specifies the total national spending for all the covered services and is broken down into different components. Operating expenses, capital expenditures like new buildings or major equipment, special projects, a reserve fund for emergencies like pandemics or disasters, and funding for health professional education.
That's a very different approach. Separating operating funds from capital funds seems significant. How does that money then flow down to the providers, like, say, a big hospital system or a nursing facility?
For those kinds of institutional providers, the main payment method is through global budgets.
Global budget, so like a lump sum.
Pretty much. Think of it as a fixed negotiated amount of money paid to the hospital, usually quarterly, designed to cover all of their expected operating expenses for that period. And the key is that payment is considered payment in full.
Wait a second. If a hospital gets a fixed lump sum for operating expenses, that completely flips the incentive structure, doesn't it?
Absolutely.
Right now, hospitals often make more money by doing more tests, more procedures, more admissions. Volume equals revenue, but with a global budget.
The incentive shifts dramatically.
Yeah.
It's no longer about maximizing volume and billable services. Instead, the incentive is to manage that fixed budget efficiently while still providing high-quality care to the population they serve. It becomes about population health management within a budget, not revenue maximization per patient.
That's revolutionary. How are those budgets decided? How do they figure out the lump sum?
The bill says the budget negotiations have to take several factors into account. Things like the hospital's historical patient volume, projected changes in the community's needs, the actual costs of labor, and this is important. It includes necessary increases to meet mandatory minimum safe nurse-to-patient ratios, which are also part of the bill. It also considers efforts the hospital is making to reduce health disparities.
Okay, and if they're operating on this fixed budget, what stops them from just cutting corners, skimping on staff or quality to stay under budget?
That's a valid concern, and the bill tries to address it in a few ways. There are strict rules about how the operating funds can be used, for instance. They cannot be used for profit marketing or major capital projects. Those come from different parts of the national budget.
So they can't just pocket the savings as profit.
Right. And there's also a mandated duty of ethics written into the law for providers. It requires them to advocate solely for the patient's exclusive interest.
What does that mean in practice?
It means, for example, the bill strictly prohibits financial arrangements like bonuses or incentive payments for providers or administrators that are based on how much or how little patients use services or based on the financial performance of the hospital. It tries to remove those direct financial conflicts of interest.
Wow, prohibiting bonuses based on utilization or, say, stock ownership in related medical supply companies? How big a change is that from how some large health systems work now?
It's an enormous departure. It really aims to sever those financial ties that can potentially influence clinical decision-making or administrative priorities away from pure patient need.
Okay, so institutions get global budgets. What about individual doctors, like the primary care physician in a small practice or specialists in a group clinic? How are they paid?
They're generally paid through a national fee schedule. This would essentially take existing Medicare payment processes, update them, standardize them across the country, and use that schedule to pay individual practitioners and group practices that aren't operating under a global budget.
Got it. Fee for service, but standardized and nationally set. Now let's quickly touch on drug costs again. We mentioned the potential $200 patient cap, but how does the system tackle the prices drug companies charge in the first place?
This is another huge piece of the cost control strategy. The bill empowers the Secretary of HHS to directly negotiate prescription drug prices with manufacturers annually.
Direct negotiation. Like the VA does now, but on a massive scale.
Exactly. That's seen as crucial for bringing down overall drug spending. Plus, there's a formulary system established to promote the use of generics and evidence-based prescribing.
Okay. One more piece in this section. What happens to the programs we have now? Medicare, Medicaid, the Children's Health Insurance Program, SEIHP, do they just disappear?
Mostly, yes. The bill states that the benefits provided under Medicare, Title 8, Medicaid, Title 19, and SEIHP, Title 61, generally cease once the full Medicare for All program starts.
Generally. Is there an exception?
There's one major exception, and it relates back to long-term care. Remember how the new M4A program covers home and community-based long-term care?
Right, keeping people at home.
Well, institutional long-term care, think nursing homes, that remains covered under Medicaid. States would still administer that piece, and they'd have to maintain their current effort, meaning they couldn't just slash eligibility or funding for nursing home care.
Ah, okay. So Medicaid isn't entirely eliminated. It retains that specific nursing home function while home care shifts to the new federal program.
Precisely. It's a key nuance.
That clarity on long-term care is vital. Okay, let's move to the logistics. Section 3. The transition. This is a massive overhaul. How is it supposed to actually happen? Is it just flicking a switch?
No, definitely not overnight. The bill lays out a transition period. The full switch, where everyone gets the full M4A benefits, is scheduled for 4 years after the law is enacted.
4 years? But it's not like nothing happens during those 4 years, right? There's a ramp up.
Exactly. There are several significant steps during that transition. First, and this is pretty quick, children under the age of 19 get immediate access to the full M4A benefits package just 1 year after enactment.
Wow, kids first, year 1. What else?
Second, people currently on Medicare see immediate improvements during this period. Things like eliminating their existing deductibles, putting a $1,500 annual cap on their out-of-pocket costs for services Medicare already covers, and importantly, adding dental, vision, and hearing aid coverage into Medicare Part B.
So current Medicare gets significantly better right away.
Yes, and the 24-month waiting period for Medicare eligibility for people with disabilities is also eliminated immediately.
Okay, that's substantial. And I remember reading something about lowering the Medicare age during the transition too, a sort of phased buy-in.
That's right. The Medicare eligibility age is progressively lowered. In year 1 after enactment, it drops to 55. In year 2, it drops to 45. And in year 3, it drops down to 35.
So gradually expanding the pool of people eligible for that improved Medicare before the full M4A system kicks in for everyone at year 4.
Correct. And perhaps the most interesting transitional piece is the creation of a Medicare transition plan. This plan must be offered as a public option through the existing Affordable Care Act marketplaces, the exchanges.
Ah, so basically a temporary public health plan run by the government available during those transition years.
Exactly. And crucially, this Medicare transition plan has to cover all the same benefits as the final M4A program, operate with a high actuarial value, 90%, meaning it covers 90% of costs on average, and use Medicare fee-for-service payment rates to pay providers.
So it gives people a taste, a real option to get into that comprehensive coverage model even before year 4 hits.
That seems to be the idea, yes. Provide a bridge and an early option.
Okay, so once we hit that 4-year mark, the transition is complete, M4A is universal. What happens then to private health insurance? Can people still buy it? Can employers still offer it?
Here's where it gets very definitive. The legislation strictly prohibits private insurance companies from selling any coverage that duplicates the benefits provided under the Medicare for All program.
Duplicates. So they can't sell a plan covering hospital stays or doctor visits if M4A covers it.
Correct. They can still sell supplemental insurance for things explicitly not covered by M4A. The bill doesn't define many of these, but you could imagine maybe some cosmetic procedures or perhaps extra amenities. But the core health insurance market, the kind most people have through work now, would essentially be replaced.
And because coverage is universal and not tied to employment, things like COBRA continuation coverage.
Right. Those requirements under ERISA are repealed. They become unnecessary if everyone has guaranteed coverage anyway.
Makes sense. Finally, within this transition and the new structure, the bill seems to create some specific new offices within HHS focused on, well, on fixing underlying problems, particularly around equity.
Yes, that's a notable feature. Two specific offices are established. First, an Office of Health Equity. Its job is specifically to monitor health disparities, looking at differences in access, quality, and outcomes based on race, gender identity, income, where people live, etc. Make that data public and recommend policies to fix those disparities. Things like promoting cultural competence training or increasing diversity in the healthcare workforce.
So it's an explicit recognition that just providing insurance doesn't automatically erase deep-seated inequities.
Precisely. And the second office is the Office of Primary Health Care.
What's its focus?
Its goal is to bolster primary care, specifically to increase access to high-quality primary care, especially in underserved rural and urban areas, and to help coordinate health professional education, like where residency slots are placed to address doctor shortages in key fields and locations.
And I see there are also whistleblower protections included.
Yes, strong protections for healthcare employees who report violations of the law or ethical standards, or who refuse to participate in practices they believe are unlawful. It reinforces that focus on ethics and patient advocacy we talked about earlier.
Okay. Wow. So let's try to wrap this up, this deep dive into the text of the 2025 Medicare for All Act. It really reveals a proposal built around maybe two huge structural shifts. Is that fair?
I think so. What are the two you're thinking of?
Well, first, the creation of this universal, truly comprehensive benefits package delivered essentially without financial barriers like copays or deductibles for the patient. That's shift number one.
Right. A shift in access and affordability for the individual.
And second, the establishment of this completely different financial architecture. A centralized national budget controlling overall spending and these new payment systems, global budgets for hospitals, negotiated fees for doctors, negotiated drug prices that completely re-engineer the financial incentives within the system.
Yeah, that's a good summary. A shift in how care is paid for and how costs are managed system-wide.
But we have to circle back to the political reality. As comprehensive as this blueprint is.
It's currently stalled. As we said, it's stuck in committee. There's immense opposition, focused largely on the projected cost estimates vary, but often range up towards, $38 trillion over 10 years, according to some analyses.
Though proponents argue those costs are offset by massive savings elsewhere in the system, eliminating private insurance overhead, administrative waste, and through drug price negotiation, potentially leading to overall savings compared to the current trajectory.
Correct. Projections by groups like Physicians for a National Health Program suggest net savings are possible. But the upfront cost and the sheer scale of the disruption make it a very, very difficult political lift.
So the debate rages on, but looking just at the mechanism proposed in this bill, the text itself, it really represents a fundamental shift in how we think about managing risk, doesn't it?
How so?
Well, the transition essentially moves financial risk away from the individual patient by getting rid of those deductibles and copays and concentrates it instead within these centralized administrative bodies, like the regional offices mentioned in the bill, who are responsible for managing those global budgets.
That's a very insightful way to put it.
Yeah.
Risk shifts from the patient to the system's administration and budgeting process.
And that leads us to a final thought, maybe a provocative question for you, the listener, to consider. This proposed structure relies heavily on centralized budgeting and regional planning to allocate resources and manage care. If something like this were ever enacted, how would that fundamentally change the priorities? How would healthcare quality and the distribution of resources be decided compared to our current system, which, for better or worse, is largely driven by decentralized market forces and that constant pressure for volume and revenue?
A very different way of thinking about efficiency and value in healthcare. Definitely something to chew on.
A structural challenge worthy of deep consideration indeed.
Don't forget to like and subscribe for the next episode on While We Were Distracted.